All right, so I have back today for the first time on video, Jaime Shoup. Trained with Jaime in medical school. He went into neurology, I went into psychiatry, but Jaime is one of the most intelligent and best critical thinkers that I know. He is able to synthesize so much information, but he's also extremely nuanced and has a great appreciation for the massive swath of unknown out there. You're super inquisitive, and you really just have a passion for learning and understanding whatever the hell it is that we're treating, and trying to just uncover more and more pieces of the puzzle over time. So
I very much appreciate the warm introduction. Yeah, that's fantastic. I'm happy to be back.
Somebody get this guy some help!
all right, so I have back today for the first time on video, Jaime Shoup. Trained with Jaime in medical school. He went into neurology, I went into psychiatry, but Jaime is one of the most intelligent and best critical thinkers that I know. He is able to synthesize so much information, but he's also extremely nuanced and has a great appreciation for the massive swath of unknown out there. You're super inquisitive, and you really just have a passion for learning and understanding whatever the hell it is that we're treating, and trying to just uncover more and more pieces of the puzzle over time. So
I very much appreciate the warm introduction. Yeah, that's fantastic. I'm happy to be back. We're going to be talking about some encephalitis today.
Yeah. So when I actually had my probable future brother-in-law, Jolly, I had him on the other day to give his kind of patient perspective. And just so you all know, when this all went down at the end of May, Jaime was one of the first people that I called. And so Jaime helped me through it. But before we get all to that, catch us up on where you're at and what you're doing.
Yeah, so I finished my epilepsy training. Going to be starting at the Autism Center here next month, and also practicing pediatric epilepsy, focusing more so on the refractory cases, the more challenging epilepsy cases, in combination with autism. So really excited, and then get to kind of springboard my research career in that regard. So there's a lot of exciting things happening.
Yeah, absolutely. And you've had, for the first time in several years, you've had a couple of months off of work, right?
Yeah, I don't know what to do with myself. The house is really clean. I've grown a garden. I have some herbs growing, a bunch of basil, and got some hobbies. I got to fill my time with something. Still researching a lot. Kind of just read for fun. It's amazing that we have them right at our fingertips. Any question you have, you can, really feed into. So it's been a good time. Been able to hang out with my kids. You know, they're now 8, 5, and 1.5, and it's amazing being able to see them grow and get this time to spend with them.
I know it's like kind of sad. Even mine are not even 1 and just turned 2, and I'm already thinking about the future and how they're not going to be babies anymore. And
it happens so quick.
I know. My son the other morning came running into the bathroom. I was in the shower, and he just rips his clothes off. He's like, I'm getting in the shower with Dada. And I'm like, man, and he's sitting on my lap in there, and I'm like, man, it's just going to be a few years before he's like, yeah, I don't want to do that anymore, Dad.
No, definitely not.
And he comes in there and gives me a big kiss, and he's just like, it really softens your heart.
Oh, man. It is.
But of course, the human mind loves to look at all the problems that are coming in the future,
Yeah. Oh,
including
gosh.
the inevitable and unyielding problem that your children will grow up.
Yeah, and it's very quick. And each stage, you think you have all the time in the world, but it's gone, and you look back and you're like, oh my gosh, you're a little kid now. Oh my gosh, you're a teenager.
Yep.
Like,
You hate me all of a sudden. Damn.
what happened?
What did I do? Remember when you used to sit on my lap in the shower?
yeah. It's like, Dad, you're so weird.
Oh man. Well, anyway, it is exciting. I'm excited for you. We are here to talk a little bit more about encephalitis, just as a background, so you are in the know. I have talked to Jolly, who experienced it. I've also talked to a guy named Philip Breton. He is an Australian encephalitis researcher and is pretty widely known in that circle around the world.
That's great.
He focuses more on pediatric encephalitis. Okay. So we've talked a little bit. He's given some overview. So we're not coming in totally blind, but I wanted to have a sit down with my local neurology expert.
Yeah. And I've seen patients, several patients with, encephalitis. Encephalitis is pretty broad, right? It basically breaks down into your brain is inflamed.
Yep.
It's a catch-all for a lot of different conditions, whether it be infectious, autoimmune, whether it be, through other mechanisms that seizures can lead to you having a kind of encephalopathy, but there probably is some type of encephalitis that occurs with a good fraction of seizures. And it...
Because you have toxic byproducts, and then the immune system, the neuroimmune system is trying to clean up those toxic byproducts, right?
Exactly. And so how the astroglial network gets remodeled following acute symptomatic seizures is a big part of this.
Yeah.
And so if you get a HSV infection, for instance, your microglia get turned on, they're trying to get things back in order. Now, there are a lot of factors that kind of lead towards the cooling off of the immune system once the job's done, that it doesn't occur the same in every person. And some people, it stays on longer, and it leads towards more hypersynchronized networks that leads towards more epilepsy. You're now having seizures without the provoking cause of the initial injury.
Yeah.
Whereas there are, immune responses that can occur based off of how we live after we have an acute symptomatic seizure. And so a fascinating experiment in this is from a doctor in Nebraska. She looked at mice and used kainate, which is a seizure inducer, to induce these symptomatic seizures. And then they checked inflammation markers in the brain immediately after, and then also, sometime later, kind of serially over a week to 2 weeks, up to 3 months afterwards. And what they did is they took some of those mice, put them in a cage by themselves, had their necessary resources, but didn't have a way to exercise, didn't have other mice.
Yeah.
Then took mice, put them in a great environment, had socialization, had, everything that they needed spiritually, in a sense, right? And what they showed is that the inflammatory markers in the isolated mice persisted for weeks and weeks and weeks afterwards. And those same mice developed epilepsy. Whereas the other mice didn't. Theirs went quickly down.
And that's with the same diet.
And same diet, same
sleep pattern.
The only change is what they were doing with them. They were gentling them also. So you take a mouse out and you pet it.
Yeah.
Releases oxytocin for the mouse, right?
Yeah.
Same with but they're similar to us. And so it shows that what we do after acute injuries, right, has a huge effect on how our brain kind of rewires afterwards, and how chronic states of dysfunction can occur following acute encephalitis or encephalitides.
It reminds me a little bit of the rat park studies in addiction.
Yeah.
How, rats in this isolated environment, which was how we studied addiction for a long time. And we've talked in other podcasts about how the rat park experiments were hard to replicate, and there may have been problems within that research by itself. But it showed that the mice or the rats who were surrounded in like an amusement park with other rats and things to do and social encounter, they didn't rely nearly as much on the drug as much as the rat that's sitting in isolation.
Exactly.
Wow. It's not that mind-blowing, is it?
and it I think it speaks a lot to kind of a neurobiologic facet of it, of being epilepsy. That's almost the furthest extent of a brain hypersynchronization.
Yeah.
Right? That's the complete breakdown of the kind of individual networks that allow for the diversity of behavior. Right?
Yeah.
And so that's very damaging, but in a kind of similar type of way, the throughput of that energy, if it's only focused in specific pathways, leads a lot of times towards a disease state over time. And it's, behavior plays a role in that, right? And how we interact with our environment afterwards plays a big role in that.
That is a fascinating study because, it makes a lot of sense when you talk about addiction, but I wouldn't intuitively think, I wouldn't think the opposite, but I wouldn't intuitively think, I need to make sure that I have appropriate social engagement as a form of, or as a part of my recovery.
Yeah. And what's interesting is our drives change with the inflammatory systemic state. So in a systemic inflamed state, our oxytocin systems don't work as well. They don't go to the brain as much. The oxytocin doesn't. So you aren't motivated by socialization because in a kind of primitive sense, that's how you lock down if you're infected.
Right.
Right?
Yeah.
And so what happens, though, is that system is sensing a lot more than just tissue breakdown, right? If your brain gets inflamed, the astrocytes start breaking down sometimes and start releasing S100Bs. And that causes this pro-inflammatory effect that leads to NFK beta. And so the NFKB is kind of this linchpin, a part of that, and it starts changing the genetic signaling towards producing IL-1 beta and IL-6 and TNF alpha, and you don't need
all
to know
these
the
inflammatory
specific,
markers.
But exactly,
Yeah.
It's just inflammation, and it's telling your system that, hey, we gotta fix things.
Yeah.
We gotta fight against it. And the thing is, our brains rely on these cells in a normal sense for other things, right? We need to have our microglia and our astrocytes working just for normal functioning.
Yeah.
Just to learn appropriately, to remodel the network so that it's energetically optimized. That's the important part, is that our brain takes a ton of energy. So it really does have to couple with our immune system and our understanding of our environment, how much food we have, how much resource we have in our body, the stores. Like, it's interfacing so many signals to try to figure out, this is what this person's supposed to do right now.
Yeah.
Right?
Yeah.
That this person, this person's actually good to have babies now. Oh, this person is not in a place to have babies now. Like, that's going on in our neuroimmune kind of system.
Yeah.
I don't know. I think it's fascinating how you can find different signals or different kind of shapes, forms, different
Markers.
Different markers, biologic markers of how the systemic diseases of endocrine dysfunction kind of trace back to hypothalamic dysfunction.
Yeah.
Right?
Yeah.
And how PCOS, for instance, is part of that.
Polycystic ovary.
Yeah. We're so much more integrated with our system than I think we realize, and how much is kind of out of our control too in that interfacing.
Yeah, absolutely. I told you he was smart. So in terms of that kind of post-acute recovery from something like encephalitis, if you got it, what kind of treatment plan would you develop for yourself?
Yeah, that's a great, I think willfully putting yourself back into normal routine things that you do is really important. Surrounding yourself with people who maybe you don't have the drive to socialize, but just being around other people. Now, granted, you're not infectious at this time. You're not in a place where it's a problem, but just once you get to that recovery phase, really working with other people as part of that network, you know, they can help rebuild your body because it senses that, hey, I'm in a stabilized network. It is a good time for me to recover still. And it's amazing how biologically we have signals to say that.
Yeah.
Diet is a huge part of recovery for anybody.
Would you recommend, like with pretty much every other condition in medicine and psychiatry, the Mediterranean diet?
Yeah. And I think the Mediterranean diet has a big upside because it minimizes the kind of carbohydrate load in a way that allows for less inflammatory signaling from our microbiome.
Yeah. And you had mentioned that earlier before we started recording, how we have so much added sugar in so much of our food that sugar attaches onto our proteins where it really is not supposed to be in that high quantity or frequency. Exactly. And then it creates a more of a vicious inflammatory cycle.
Exactly. And so we see this specifically with diabetes, which you can use as a model of excessive glucose, right? Glucose, just by virtue of being around things, can react with our proteins, particularly lysine likes to do this, one of our amino acids. And when it does that, that protein no longer works like it's supposed to. And our bodies have to figure out how much of that is occurring in order to kind of repair the things that are going on, right? Yeah. And so if there's too much, though, and there's too much backup in your metabolic pathways, then you end up getting basically this inflammation that occurs at different levels in the body. The microbiome, our gut, being a big component of this, right? And signaling there then can kind of, everything that gets broken down there becomes a chemical that gets taken up and ultimately changes the substrate for our brain and for our system, right? Yeah. And so our fats, for instance, they get broken down into these short chain fatty acids, butyrate, propionate, and acetate. Okay. These go to the brain and they have real effects on our astrocytes and how our microglia function. They change how our liver expresses genes. And the thing is, there are other markers that we use too, but this is just the fat component of our diet. And different bacteria in our gut break down fats differently. So you are not just one type of bacteria in your gut. There's lactobacillus, there's bifidobacterium, there's clostridiums, there's all these different species, and they all break things down differently. So what you feed them determines the community that you have.
You got my brain going with, and it's such a simple idea that all of our systems are interconnected. Even though we do an autopsy or we are in the cadaver lab in medical school and we dissect one part at a time, but you had me thinking about all the way back to organic chemistry, and I had a professor who would talk about how and why Diet Coke and these essentially fake sugar can be so harmful to us. But he focused his conversation on the increased risk of colon cancer because these huge, bulky, 14, 16, 18 sugar molecule compounds are a disaster for the body to break down. Whereas, to give a comparison for the viewers, listeners, something like fruit, which comes from the term fructose, which is two sugar molecules connected together that is so easily cleaved early in its digestion, creating energy that is readily accessible and doesn't have to, your body doesn't have to do a lot of work after that to access it. You just got me thinking about these fake sugars or things that, don't ever get into the brain, but they instigate inflammation that does not just stay specifically in the gut.
No, and has downstream consequences to how the brain functions.
Right.
Different species are much better at breaking those things down than others, right? And what ends up happening is you feed them. And if you're eating just that source, that population takes over. And you get a bacterial overgrowth within a specific type. Now, what's interesting is each biomolecule that we have kind of ties to specific bacterias and Clostridium as well, or sorry, not Clostridium, Candida. So fungal spores as well. Fungus also plays a role in this as well. But lactobacillus is one that is found organically in breast milk. It's a very important kind of initial colonizer, right? The first bacteria that we get from our mom come through the vaginal canal and then our diet and the milk microbiome that is kind of being produced. So even the establishment of the microbiome after that will shape that person's relationship to their kind of environment for the rest of their life.
Yeah.
Which is fascinating, right? That something as simple as breastfeeding, which all mammals do, right? Yeah. Something very important to our evolutionary tree and kind of makes us different than the rest of the animal kingdom, right? Is it starts with the microbiome getting established, and then lactobacillus actually tells the enterocytes to produce oxytocin.
The small intestine cells.
The small intestine cells. Sorry, I get on.
I got you.
Roll,
You're good.
the small intestine cells start releasing oxytocin, and that process changes behavior. So even something on the level of changing your gut is having a huge effect on your brain and how you learn how to interface with your environment for the rest of your life. Yeah,
that's incredible, and it's just, I have fun talking to you because you send me down those roads of thought of things that I'd never kind of put together before. That downstream inflammation in the gut can also create inflammation in the brain because we're all connected, and you're responding to markers and
exactly. And we have mechanisms to try to kind of compartmentalize things, right? We have in a healthy system, our gut tries to have tight junctions, tries to make it so that, hey, a lot of the bacterial products, LPS being one of those, lipopolysaccharide, which is found mostly on E. coli's and gram-negative type of bacteria, but it was evolved to, once that gets into our system, inflammation. Like, we need to fight that off. That is not in the right place, right?
Yeah.
Which also has effects on the microglial activation. And LPS has a huge effect. You get sepsis, that's going to change your behavioral pattern simply by that inflammatory response. GABA, which is our kind of main inhibitory neurotransmitter.
Yeah, it brakes on the brain.
Yeah, the brakes on the brain. It comes from a very specific bacteria. There are very specific bacteria that are involved with that in the production of GABA and things like that.
Yeah.
Dopamine, same thing. You break down the molecules in your food, and it produces these phenol groups. One of which, I'm trying to remember the name, P-crestal, and that gets transported and made into brain dopamine and seems to correlate.
Yeah.
And how very specific types of bacteria, again, are involved in the metabolism to make this P-crestal. So I don't know, to me it is beautiful that we are these like diverse communities that if our behaviors and how we eat and what we eat play a role in how our brain develops and how it ends up learning what is available to it, what is going on out there.
Yeah.
Right?
If he lost you there in the last 5 to 10 minutes, the bottom line is you are what you eat.
Yes. That is 100% what it is.
Well, to jump back to encephalopathy, or encephalitis. So, again, imagining that you were the person who contracted it and you had your acute recovery, what would you expect in terms of when do you think it would be reasonable for you to be followed up with by your neurologist or by really, ideally, your neurologist?
Yeah. So it really, one, depends on your acute complications, right? If you had acute symptomatic seizures in that first time, how difficult they were to control, right? Someone comes in with super refractory acute symptomatic seizures, meaning we try 2 conventional anti-seizure medicines still going on. We try benzodiazepine still going on. We put you on a drip. After 24 hours, seizures are still going on. We titrate, stops. Well, that person is at a much different position than somebody who has 1 seizure, doesn't have another one, right? So when to follow up is going to me, have to do with what happened to them in that time. Seizures being a big part of that. Because HSV encephalitis, for instance, tends to have a high temporal lobe epilepsy risk. So following up within what I would say a month to a month and a half, 2 months, at least checking in.
Yeah.
Right.
What about 3.5 months?
That's pushing it. That's a little long.
That's the earliest that Jolly was able to get in with the neurologist. Now, he has been able to see his primary care, who actually, a new primary care, because he didn't have one before, who is pretty knowledgeable about it all, honestly.
That's good. And that's very helpful to have in the medical infrastructure. Shout out to primary care who can kind of fill that gap, which we certainly need with specialists. There is, unfortunately, not as many specialists, and so you are at the mercy of, how much resources available and where they're at. Ideally, I think sooner, really just to kind of see how, and it probably won't change much. It doesn't even have to be a full visit. You can see them and just make sure, hey, you're not having seizures, you're not having personality changes, you're getting back. Like just making sure and asking the questions, and just kind of checking in, I think is important. But we also are in an age of technology where interfacing through text messaging, just text through the EMR, right?
Yeah.
Like, I encourage my patients to check in much more frequently than my follow-ups.
Yes, same here.
And I think it's important to, one, give the good counseling of what is the possibility of bad things that can happen after acute, encephalitis.
Yeah.
As far as HSV encephalitis, the rate of seroconversion for NMDA afterwards, in some studies, is upwards of 30%. So a post-infectious autoimmune response following an acute encephalitis, that needs to be known, and people need to know exactly. And that's why I think, at least for that case, it's really important to have sooner follow-up. So that
how long would you, managing a patient, or if you had it yourself, how long would you remain on essentially a prophylactic anti-epileptic?
Again, so if it's prophylactic, and I don't know exactly which one. Was it Keppra? Was it
Keppra? Yeah.
You know, there's not great evidence to suggest even in acute injury, acute encephalitis, that using a prophylactic like that is going to have much of a difference in terms of epileptogenesis.
Yeah.
My general feeling is that if you didn't have a acute symptomatic seizure, okay, that taking it is not going to make a big difference. But if there is signs of irritability on EEG, keeping it on, you know, it's not going to make a big negative. It's low risk, so I think keeping it on probably for 3 months is reasonable, and then afterwards taking off.
So remember, he had the interictal continuum showing
That's
on
right.
the EEG,
That's right.
which is
He
kind of a
did,
non-specific
It's-
finding that could be related to the infection itself.
Yeah.
Could be related to an epilepsy. But
Yeah.
you tell me more about...
So interictal continuum, it's hard to say whether it's a seizure or not. And at that point, it's you can kind of consider it status. I would consider it status epilepticus, because if he's, and it depends on his clinical symptoms, right? If he's not speaking, he's completely encephalopathic, and he has that pattern, and that's a huge departure from normal, yeah, that's probably seizure going on, right?
Wasn't a huge departure. It wasn't enough of a departure to immediately be like, something's wrong, but it was immediately like, he's acting really funny and strange.
So he's not baseline. And from a focal standpoint, if you have those discharges going on and he's altered, I would say he's clinically having symptoms. And treating it with a benzo, or treating it, usually it's a benzo that we try first. And if you give it to him and then he improves, yeah, that was a seizure he was having.
Yeah.
And it is interesting how it's the firing rate that makes it that. So if you synchronize,
and I don't think the benzo, when they first gave it to him, did not have that effect on the EEG reading.
Yeah. So the thing is, it's a spectrum of hertz, and so it depends on how fast those bursts are coming, and if it's 1 hertz to 2.5 hertz,
that's an IIC, right?
That's an IIC.
Yeah.
That's kind of more. We don't know if it's having an effect on your brain or not. You need to clinically correlate it.
Right.
But if it is, you see the person, they're not acting normally, then you probably should err on the side of it's seizure going on right now. It's ongoing seizure. So in his case, I would say depends on what you're doing, right? It's all a risk versus benefit kind of analysis. And if you're not working, you're not driving, you could try coming off. Worst case, you have a seizure.
Right, which everybody is terrified of, but I try to reassure people that 99.9+% of the time, having a seizure is not fatal. It doesn't lead to a lot of like downstream acute complications.
No, and it depends on how long the seizure goes on and how frequently the seizures go on. So having one seizure, 95% of the time, that seizure is going to stop within a minute.
Yeah.
It's not going to cause a significant damage to the brain. That's not a hypoxic state.
Right.
As you can think of, a relative hypoxic state, which is a lack of oxygen. Your brain's not getting it. But if it's firing like crazy over 5 minutes, we start to have more kind of anoxia occur. We really don't, from models, see damage until about 20 minutes to 25 minutes after having an acute symptomatic seizure, or a seizure, just a seizure leading to pure anoxic damage that leads to long-term effects, right? Yeah. There are, kind of phases that you can think of. And if it's going on less than 2 minutes, it's probably not going to have a long-term effect on the functioning of the brain afterwards. It is important for that small group who doesn't have it that they have an abortive agent, a rescue agent.
Right.
And so for him, if he's ever thinking of coming off of that medicine, which I would encourage, you give him that. And you say,
you have Ativan on the side.
Exactly. You have Diastat, you have Valtoco, you have, these things which they go right in the nose. They're pretty easy to administer. And it can stop that seizure if it were to go on. So you're covered. So you can feel comfortable at that point. And his brain then tells you he's going to be on this medicine for 2 years now, that we're not going to revisit this for a bit.
Yeah.
Right?
Yeah.
And so seizures are bad.
But even at that point, there is still potential for long-term recovery.
Yeah, certainly. And the age with which it happens makes a big difference, right? If you have an autoimmune encephalitis when you're 14, your brain may rewire differently than somebody who's in their 30s.
Yeah.
Right?
Or than somebody in their 60s.
Yeah, exactly. And so it makes a complete difference of how much our genetics can change, how much our brain's trying to learn of what the environment is. Sometimes being younger is better from a recovery standpoint, but sometimes the network gets formed incorrectly after it has a huge hit like that.
I gotcha.
For him, he has no further seizures after, say he stops it in 3 months, 6 months, he stops it, they go on, try it cautiously a year, probably. Very cautiously. I don't think you necessarily have to if he has no, things. The thing is, it also has to do with who's around him. If someone lives by himself and they have a subtle mesial temporal seizure, which is most likely to happen for him, he may not know he had it.
That is so. It is so important when questioning a patient about their seizure history. I deal with more of the full-blown tonic-clonic alcohol withdrawal, benzo withdrawal seizures that are more obvious. But even then, somebody who's having a seizure, you don't have the ability in that full tonic-clonic state to be aware of what's happening.
No.
You don't have insight. Now, you may feel drastically different when you come out of it and you wake up from it.
Yeah.
That postictal state.
Exactly. And so generalized seizures, usually they do know afterwards because it affects their dominant hippocampus, their dominant memory centers. Our brain lateralizes in a lot of regards memory, and it lateralizes language. So following a seizure, if it's on your dominant memory side, you do usually not, you don't know, because that area is not encoding it. It didn't even know that it was happening, or your awareness may be not altered during a seizure if it's on your non-dominant, but if it's your dominant, your awareness is affected. It plays a big role with focal seizures, especially in these cases, which encephalitis for the most part, HSV specifically, it's more of a temporal type of seizures. So knowing the focal nature of what could happen is important. And usually with HSV, I don't know with his image, did he have both sides affected? Did he have anything on his image?
He was still in such an altered state going through the MRI machine. He didn't really understand the importance of it and was kind of flailing, thrashing about. So there was a lot of artifact on the MRI of his brain.
I think if he were to have subsequent symptoms and wants answers, I would probably recommend getting an interval MRI at some point to see if he develops hippocampal sclerosis.
Right. And I had talked to him about that, going just outside of the typical medical system. Go get your MRI done, and then we will find somebody to read it for you.
And really doing it later and not in the subacute phase.
Right.
So really doing it once everything's kind of settled, then you can kind of prognosticate, I think, your epilepsy risk best.
I gotcha.
And you may be able to have better understanding of maybe mood issues that are arising and things like that. Now, whether it changes what you do.
Right.
I think from a prognosis standpoint, though, checking to see if he has sclerosis is going to be the biggest.
Yeah. This whole topic of conversation kind of illuminates a bigger overarching issue in my field of psychiatry. Syphilis used to be a psychiatric condition. Then we figured out that there is a organism that causes that, and it became a neurologic condition. Things like this that lead to a very biologic thing that's happening in somebody's brain that lead to prominent behavioral abnormalities, sometimes without any focal neurologic deficits. How would you decipher this working in the ER, especially if you encounter somebody that has pre-existing severe mental illness?
Yeah, that is a great question. One thing that can really help tip you off to an organic disorder in these senses is autonomic dysfunction. So,
And what do you mean by autonomic?
Autonomic heart rate.
Yeah.
Breathing changes, pupillary dilation, sweating, things that aren't normally under volitional control, right? Things that are kind of just happening. Our brains are interfacing with it, with our autonomic nervous system. And you do see more so in acute encephalitis changes in that regard. Now, it makes a difference what type, right?
Yeah.
If you're going to have an infectious encephalitis, you're probably going to be febrile too, or you're going to have other inflammatory things going on. Whereas if you have an autoimmune encephalitis, the autonomic dysfunction can be really helpful for you.
Yeah, we've had a couple of autoimmune encephalitides on the psych unit. One of them was a lupus cerebritis, where the patient unfortunately had onset of psychiatric major behavioral disturbances later in life, in her late 40s, early 50s, bounced on and off of psych units. And I think another thing to add to what you said, especially maybe not in the acute setting, but more in the subacute or chronic treatment, is people who are not responding to typical psychiatric medications that would help with some of those symptoms of psychosis, is what that woman was dealing with. And unfortunately, at some point, her brain herniated.
Oh. Yeah, and swollen too much.
Just too swollen, herniated, and that was that. But it was only after the fact that, through autopsy, that it's discovered this was related to an autoimmune condition.
Yeah, I give another example, and this was more of an infectious etiology. But a man in his 40s, late 40s, came with seizures. And behavior changes, more behavior changes than seizures, but it did through history seem like he was having some focal seizures. Was ultimately was stabilized because behavior became more of his issue, and was discharged. And he continued having these episodes that were probably seizures, weren't getting treated, but was mainly getting treated for psychiatric illnesses.
AKA giving him medicines that make him more likely to have seizures.
Yeah, exactly. And, it gets worse. He ended up having a psychiatric break, got admitted to the psych unit, and this is 3 months later, through some more history, they were like, oh, this is weird. We're going to get neurology on board. See, first of all, anyone having acute seizures in their 40s probably needs to get a more thorough evaluation. But it unfortunately took 3 months for this man. They did an image, and he had pus all through his frontal cortex.
Oh,
and
God.
He had a sinus infection that ate its way through and was in his frontal cortex. So this man was having frontal lobe seizures and behavior changes, was billed as just a behavior change issue, was more psychosis, when it was really just an infection in his brain.
And I worry about that with anybody in general. I think luckily for Jolly, he was 35, and it's not a very likely age to have the onset of something like bipolar mania, or, I had heard that he hadn't slept in 3 days, and then he had these major behavioral changes, the lack of insight, and the psychiatrist is thinking, well, is he manic? Well, he's laying in bed. That doesn't really add up. He's not making a whole lot of sense. But it frightens me for how, and it leads into my next question, which is, I don't expect like a legitimate or actual answer, but how prevalent do you think not just encephalitis, because that's probably still pretty rare on an inpatient psychiatric unit, but in general, how prevalent are any other neurologic medical cause of the psychiatric illness? And you could even argue that all of it.
Yeah.
That once we figure out what more about the cause, then we would label it a medical problem. But how prevalent do you think it is to have something that really requires a drastically different treatment approach, where people end up on a psychiatric unit?
That's a excellent
Loaded
idea.
question.
It's a loaded question. There's a concept of, the difference between neurology and psychiatry being focality, the ability to pinpoint the mechanism. With psychiatry, you can't 100% pinpoint the mechanism because it's a lot of factors of, environment, interfacing with genetic factors that lead to whatever, right? And so it's a lot harder in that sense. I do think that, autoimmune encephalitis in general, there's a risk for that going undiagnosed. And the thing is, a lot of those organic disorders, the longer they go untreated, if the body doesn't fix itself, which a lot of times it doesn't, they're going to start showing organic signs, meaning they're going to start seizing.
Right.
And so
they're going to have word finding difficulty.
Yeah, it's going to spread to other. So the real question is, how long does it take for someone to get
You literally
treated?
read my mind. That was going to be my next question on the autoimmune encephalitis branch of things is, how often are people able to recover from it without treatment, which is, again, another loaded question that we probably don't have enough.
So that's hard to do because they didn't seek treatment. And
you never
know.
It's something that could have been a cult the whole time, and then it fixes itself, and you never ever knew about it.
Exactly.
In general,
and short of doing large scale studies, antibody panels on healthy individuals, which we don't really have.
And who's going to do that? Because there's not any profit to be had there.
Exactly. But it is interesting. It makes you wonder, is there the potential for low concentration NMDA antibodies that do alter behavior and we're just not aware, right? HSV, for instance, extremely common. Right? We live with these viruses. We have antibodies that mimic our own receptors, and in a healthy sense, we're supposed to get rid of the ones that are going to target us, right? We're supposed to get rid of them. Those who have poorer mechanisms end up having a mounting response, so then it ends up leading to these severe, presentations. But how tolerant is the system to low dose antibodies? That's a good question.
I mean, it's all an ongoing balance playing out, right?
Yeah.
It's not like your immune system sitting here right now, or my immune system. The amount of neuroinflammation that we're dealing with right now is not zero.
No. Yeah,
absolutely. It's not zero. And how much do those fluctuations? And it, we could bounce right back to the beta amyloid theory of Alzheimer's, and how long does beta amyloid have to be there to disrupt the connection? Is that what we're seeing? Is the inflammation?
I actually don't think that beta amyloid is the primary destructive force that's leading to the issue.
It's a fallout. It is a secondary sign of damage that I think has already been done.
To an extent, I think it's occurring concomitantly, and it is through this rage system that I talked about.
Yeah.
So APP gets transported out of the brain using rage.
Yeah.
And so if your brain is constantly inflamed with this, you're not going to be able to clear these things. There's a lot of things that are problems with inflammation going on in the brain.
Yeah.
Not just that this is accumulating. So it's accumulating because of a byproduct of the problem.
Right.
Right.
Which is why all the beta amyloid removal medicines don't actually really work.
No, because you didn't change the functioning of the brain.
Or if
otherwise.
the protein that's accumulating in there has already disrupted the matrix,
Yep.
you can't just take it out and, it's like if you have a intricate, spider web that you dip your finger into, and when your finger's in there, you've already disrupted it. But then the minute you take that finger out, you're going to pull strands with it.
Exactly.
And so functionally, that's a big bane of my existence is all of these beta amyloid drugs that these companies and these researchers are so behind the eight ball.
Yeah.
I think they have to know that they really don't work that well.
Yeah.
But they've poured billions of dollars into
Massive.
the R&D, the research and development side of it.
Yeah.
So now they're in this stage of we're going to try to say that it works and try to recoup some of our money. But there's another one that the oral one that just got FDA approved too. But
it doesn't end up. I think we will find that it doesn't end up changing. What you really should be doing is putting money towards changing the system in a chronic sense, so that the energy doesn't get backed up like that.
Yeah.
And in a way, this is Friedland's microbiome dementia stuff. I think a big part of that is also the inflammation and the rage system is interfacing with it. And there's a lot of literature in Alzheimer's that's the big problem. Is you're basically predisposing your metabolism towards this more inflamed state that over time causes just degradation in the neurons, and
which is why and how I think the low doses of lithium are helpful, because they feed back through that GSK3 beta system to decrease overall inflammation and help, as we were saying, like Alzheimer. Our brains right now are in a constant equilibrium of degeneration and regeneration, or accumulation of toxic metabolites and cleanup of those toxic metabolites before they disrupt anything.
Exactly. And a big part of this is our sleep-wake cycles.
Yeah.
And a major problem that we face in today is our sleep disruption. Because of the energy, you talked about the technology and all of those things, that is a constant load on the brain. And then we're also not getting good sleep because of the amount of light and things that we're having.
We also distract ourselves from ourselves all day. And then we lay down to go to sleep at night. And we're like, why can't I sleep? My mind won't stop talking. It's because you've been trying to ignore it all fucking day.
and it becomes a new set point in a way. And what's interesting about restorative sleep, actually N3, N4 restorative sleep, you double the CSF flow.
Yeah.
You're getting rid of a lot of that stuff during the day that is accumulating and causing damage, and so it's all part of that balance. And it really does harken back to just like good sleep and exercise and good diet.
And I remember with especially some of my early bipolar patients, I was hesitant to call them bipolar because they didn't have the classic sleep disturbance of I'm getting more manic and I'm sleeping to the point, less and less, to the point where I'm not sleeping at all. But a lot of people don't have that. They probably they're still getting 6 hours of sleep. But sleep study wise, they're not getting into the restorative phases of sleep, and so
fascinating.
They may not be cleaning up their brain to the degree that they need in order to break out of that vicious cycle.
Yeah, that's an interesting kind of phenotype to consider, right? That you're not quite to the point of decoupled where you're bipolar, 1, 2, but that you are this kind of, in a way, just below that. But
I had a patient the other day who had never really had this, any sleep disturbance beyond 6 hours a night. That was the worst, but he was clearly manic. And only after talking to his sister, who deals with the same condition, who said, I never had insight into the fact that I wasn't sleeping, but later on I found out that I wasn't getting any sort of restorative sleep. I was sleeping. I was getting the initial stages of
You were
light sleep.
We call that behaviorally sleeping, biobehaviorally sleeping. When we look at EEG, we can see someone, but then their brain is doing things that it's like, no, it's actually still pretty. It's firing quite a bit, and it is interesting the oscillatory nature and how part of our day to day is the speeding up and the slowing down of the oscillations. Yeah. And we have to be able to appropriately do that at the right times to function. And how people who have these mood issues, particularly the bipolar, the more of those circadian type, I think that's the problem. It's their oscillations are completely off. They're firing all at once for long periods of time, and then they crash because of it. And it's like getting to that decoupled state and how bringing it back to lithium.
And that's also why social rhythm therapy is an effective treatment for bipolar, where you force yourself into routine.
Yes.
And you have better control over those oscillations, or the oscillations are more predictable.
Exactly.
Right.
Exactly. And I think there are things that we should be mindful of, and of socialization, that we should be not forcing ourselves, but we've gone away from the society where we have direct one-on-one contact, or we have group contact with people as much. Yeah. And I do think that we've kind of disrupted our biologic mechanisms of energy expenditure, because our network from a social standpoint has degraded.
Yeah.
It's fast, and the oxytocin network and AVP, that ends up breaking down as people age. And traditionally, you had families who had their elderly with them, right? They were still interacting with them. They were still a part of it. It's completely different when you put them in a isolated situation
where they don't know anybody and they're not familiar with the environment that they're in.
Exactly. And all of those oxytocin networks that they formed are useless for them now.
Yeah.
And it's, in a way, it's kind of sad.
But damn it, Jaime, it's such a big market. All right.
Well, someone's making money off of it.
There's so much money to be made that you can then one day take to your grave and into the afterlife with you, right?
Oh, I can't. Well, maybe you can make a nice statue and people will remember you that way.
And then you can pay God in indulgences and get in through the heavenly gates.
Fantastic.
All right, let's call it.
All right. Well, thank you for having me.
Absolutely.
I appreciated this.
We'll do it again. We'll do it again.
Definitely.
Hey, just wanted to give you a quick message to wrap up the series on encephalitis. Hope you enjoyed it. It is a huge topic and could be expanded even further, maybe in another series or episode, if we talk about encephalopathies and include non-infectious causes of brain swelling or change in behavior or change in any of our brain's functions. Some general takeaways. So encephalitis, viral encephalitis, bacterial, autoimmune, but especially the viral and the autoimmune encephalitides, they can be really scary and unpredictable. Jolly didn't see his coming at all, and it really wasn't extremely obvious to those who knew him very well and were surrounding him. We certainly don't want to miss these when we're looking at a patient in the ER or looking at a patient in the psych ER or even on the psychiatric unit. And it's our job as mental health providers, specialists in psychiatry, to ensure that our patients are not suffering from a medical cause of their altered behavior, something we fall way short on doing in the current system as it is. So we don't want to miss these, and for as little as we know a heck of a lot more than we used to, and we can actually find ways to diagnose these and treat these. And early recognition and aggressive treatment is extremely important. So it's very reasonable for folks to cast a wide net and not to delay treatment because the complications can be so serious and severe. In terms of recovery, like everything in America, we got to get better at eating healthier. We've got to stop, be cognizant of how much added sugar is in our foods. Be cognizant of what processed food does to our bodies. And I get it. It's good. It's delicious. It satisfies that I want it now, instant gratification. It tastes good. It's very sweet. It's very salty. But ultimately, it's not leading us to the long-term outcomes that we want. Also with recovery, Jaime Shoup really emphasized the importance of returning to a sense of normalcy, and also positive social interaction, being aware of the risk of seizures and tackling that head on. Coming off of anti-seizure medicines with the help of a professional, and being open to the possibility that may be something that persists for months, years, or even a lifetime. But on that note, in a psychiatric sense, this is a situation where you're battling a lot of uncertainty. There can be a fear of recurrence. But for those reasons, if you do end up having to be on an anti-epileptic for the rest of your life, also, we have got to consciously insert our gratitudes into our lives. Our minds, our survival centers in the center of our brains, they don't care about the things that are going well. They are there to let us know about all the things that we haven't done that would help our survival, and all of the things that we maybe need to look out for. So consciously inserting our gratitudes, consciously deciding the lives that we want to live, and then using our minds as tools can be so important for post-encephalitis recovery, but also for life in general. Easier to say than to do, but definitely the more practice we put in, the better we can get at it, and the more stable internal lives that we can live. Anyway, hope you enjoyed the series on encephalitis. If you got an idea for a topic, if you are a patient that has had a difficult time or a unique condition or case, please reach out. I would love to interview you and get more patient perspectives on these things that I talk about. Thanks for listening. Thanks for watching. Like, subscribe, do all those things that I'm supposed to tell you to do, and get our viewership, maybe over 100 folks an episode. Thanks.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment.
Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.